Welcome to Board Pearls. This is episode 4 of the Liver Tumors and Transplant chapter in the Liver Disease module. This episode is liver transplantation, how patients are scored and listed, the exception points for the diseases, the score undervalues, the donor types, the post-transplant complications and rejection, and the recurrent disease patterns that decide long-term survival. Allocation starts with a score, and the score has to be a faithful proxy for how likely a patient is to die soon without a graft. The current allocation score does that using creatinine, capped so that severe renal failure doesn't dominate, bilirubin and INR for the liver's synthetic and excretory work, and sodium, because hyponatremia tracks the splanchnic vasodilation of advanced portal hypertension. It also carries two terms worth understanding, because they correct real undervaluation. Female sex adds points, and the reason is mechanical. Women have less baseline muscle mass, so at the same kidney function their creatinine reads lower than a man's, and the older scores misread that lower creatinine as healthier kidneys and gave women fewer points than their disease deserved, producing a weightless mortality gap that was a math problem, not a biology problem, so adding a sex term recalibrates it away. Albumin works the same way in the other direction, subtracting points across the low range, because a very low albumin marks catabolic, decompensated disease that the lab score otherwise misses. Referral for transplant has two triggers. The first is decompensation, meaning variceal bleeding, ascites, encephalopathy, hepatocellular carcinoma, or hepatrenal dysfunction, each of which moves the natural history into territory where transplant survival beats medical survival. The second is the number, a score of 15 or higher, and that threshold isn't arbitrary. Below it, the perioperative mortality of the operation itself exceeds the short-term mortality of just managing the patient medically, so listing waits until 15, the point where the operation stops being a net loss. The workup is built to answer 3 questions, and each one decides whether transplant can actually succeed in this patient. The first is medical. Can the recipient survive the operation and the physiologic stress right after it? Cardiac screening is heavier than for ordinary surgery, because end-stage liver disease drives both cirrhotic cardiomyopathy and accelerated coronary disease, so stress imaging or angiography is chosen by age and risk. Pulmonary screening uses a blood gas and bubble echocardiography to find hepatopulmonary syndrome and portopulmonary hypertension, both common and both able to change candidacy. Renal evaluation identifies who needs a simultaneous kidney, and cancer screening matters because immunosuppression accelerates many malignancies, and a hidden one is a contraindication. The second question is infectious. What is the recipient carrying that immunosuppression will unmask? The hepatitis, HIV, CMV, EBV, tuberculosis, syphilis, and strongyloides screens are canonical, and the CMV and EBV results aren't just paperwork. They set the post-transplant prophylaxis. Dental clearance clears oral infection foci that become hard to manage once the patient is immunosuppressed, and vaccinations get finished before listing because live vaccines are contraindicated afterward. The third question is psychosocial. Can the recipient adhere to a complex lifelong regimen, evaluated by support, stability, prior adherence, and substance use? For alcohol-associated disease, the field has moved off a rigid 6-month sobriety rule to formal structured assessment of relapse risk, after selected patients transplanted early for severe alcoholic hepatitis not responding to steroids showed acceptable survival, the principle being that a structured assessment predicts relapse better than a single date on the calendar. 2 things are easy to underweight. Sarcopenia and frailty predict weightless death independent of the score, and the most reproducible measure is the skeletal muscle area at the 3rd lumbar vertebra on cross-sectional imaging, below 50 in men and below 39 in women defining sarcopenia, with grip strength and walk tests adding functional information the lab score can't see, so a patient with a moderate calculated score and severe sarcopenia is sicker than the number says. And every candidate with portal hypertension gets a screening endoscopy, including those with portal vein thrombosis, because the thrombosis can generate new varices. So listing is straightforward once the pieces are in place. The calculated score does the primary triage. The workup confirms the operation can succeed medically, infectiously, and psychosocially. The threshold is decompensation, or a score of 15, and the sex and albumin corrections fix a real undervaluation of severity in women and in catabolic patients. The next problem is that the calculated score doesn't capture every life-threatening liver disease, because some patients are dying of their liver while the labs look deceptively fine, and exception points correct that mismatch. The largest standard exception is hepatocellular carcinoma within the transplant size criteria, which after a 6-month wait receives a regional median score, and that wait is deliberate biological selection, because aggressive cancer declares itself by progressing beyond criteria during the wait, so the patients still within criteria at 6 months have biology likely to stay controlled after transplant. Downstaging into criteria with locoregional therapy counts once imaging is stable for 3 to 6 months, on the same logic. Hepatopulmonary syndrome earns a standard exception when the arterial oxygen is under 60 on room air, with a documented intrapulmonary shunt and no significant lung disease. Because the hypoxemia is driven by the liver disease and reverses after transplant, when the splanchnic circulation normalizes and the lung dilatations resolve, and the threshold of 60 picks patients sick enough to justify the operation. Portopulmonary hypertension is the mirror image with stricter rules, because its lung lesion is less reversible. The exception applies when the mean pulmonary artery pressure is under 35 after vasodilator therapy with a resistance under 400 and a transpulmonary gradient under 12, and a testable boundary is the top end, because a mean pressure over 50 is an outright contraindication, since a right ventricle reperfused into a fixed high-pressure pulmonary circuit fails on the table, so moderate disease can be brought into the window with vasodilators while severe disease cannot. Beyond those, a review board adjudicates the clinical syndromes where the score undercounts morbidity. Cholangiocarcinoma under the neoadjuvant transplant protocol, primary hyperoxaluria, often done as combined liver-kidney, familial amyloid polyneuropathy, cystic fibrosis with an FEV1 under 40%, sclerosing cholangitis with recurrent cholangitis refractory to every other therapy, Budd-Chiari or recurrent hepatic hydrothorax not eligible for TIPS, with the hydrothorax held to strict criteria of weekly large volume thoracentesis over 4 weeks, with a transidate and no heart failure, unresectable hepatic adenomatosis, isolated liver-only neuroendocrine metastases, polycystic liver disease, hereditary hemorrhagic telangiectasia with high-output cardiac failure, and epithelioid hemangioendothelioma. The unifying idea is that these are diseases killing or disabling the patient while the number stays low. Donor type is the second variable, and it maps directly onto the complications to expect. The standard deceased donor after brain death has the shortest warm ischemic time because circulation is maintained until cross-clamp. Donation after circulatory death allows recovery after cardiac arrest, but the longer warm ischemic time injures the microvasculature feeding the biliary epithelium, so it carries a higher rate of ischemic cholangiopathy and primary non-function. And normothermic machine perfusion, which perfuses the recovered organ with oxygenated blood at body temperature, has reduced that injury and made marginal organs usable that would once have been declined. Living donor transplant gives the recipient a partial graft, usually the right lobe in an adult, and its complication signature is different, with a higher biliary complication rate than a whole organ, because the cut surface and the smaller duct anastomosis are more demanding, so its role is for high-symptom, low-score patients who would wait too long for a deceased donor organ and for time-sensitive cancer at risk of progressing, since a patient miserable from refractory ascites at a score of 14 won't be allocated a deceased graft before further decompensation, and a living donor may be the post-transplant care splits into 2 stories, and both are organized by time, because immunosuppression intensity is highest early and cumulative toxicity builds late. Immunosuppression steps down over time. Induction at transplant is high-dose intravenous steroid, sometimes with an antibody agent. The first months use triple therapy of a steroid taper, mycophenolate, and a calcineurin inhibitor at higher targets, and after about a year, maintenance drops to calcineurin inhibitor monotherapy at lower targets, because rejection risk falls with time, and the goal is the least immunosuppression that still prevents rejection. The complication timeline follows that exactly. The first month is dominated by surgical and technical problems. Hepatic artery thrombosis, which presents with biliary ischemia and severe graft dysfunction and qualifies for urgent relisting. Bioleaks from the anastomosis, primary nonfunction, and the gram-negative and fungal infections of any major abdominal surgery. The first year is the peak window for opportunistic infection because immunosuppression is highest, with CMV the most common, alongside pneumocystis and aspergillus, and this is when acute cellular rejection peaks, biliary strictures appear, and early recurrent disease begins in hepatitis B, hepatitis C, and aggressive cancers. Beyond a year, the problem shifts from acute risk to cumulative toxicity. The calcineurin inhibitor drives progressive renal injury, de novo cancers emerge with skin cancers most common, and squamous cell exceeding basal cell, reversing the usual ratio, along with viral-driven cancers and post-transplant lymphoproliferative disease, and metabolic syndrome from steroids and calcineurin inhibitors becomes a cardiovascular problem, while colon cancer is elevated in sclerosing cholangitis patients with ulcerative colitis, so annual colonoscopy is part of the plan. The drug toxicities follow from mechanism. Steroids drive hyperglycemia, weight gain, osteoporosis, cataracts, and mood changes. Mycophenolate blocks lymphocyte purine synthesis and produces dose-dependent leukopenia and diarrhea. Tacrolimus is the central agent and the central toxicity. Acutely, it constricts the afferent arteriole and raises creatinine. Chronically, it produces interstitial fibrosis and tubular atrophy. At high levels, it causes tremor, headache, and seizures, and it drives hypertension, hyperlipidemia, post-transplant diabetes, and hyperkalemia, with cyclosporine sharing the profile and adding hirsutism and gingival hyperplasia. The mTOR inhibitors are different, causing hypertriglyceridemia, fluid retention, mouth ulcers, proteinuria, and impaired wound healing, but being less nephrotoxic, which is exactly why they're the conversion option when tacrolimus-induced renal failure becomes the dominant problem. Acute cellular rejection occurs in about a third of liver transplants, usually in the first 6 weeks, presenting as rising transaminases and alkaline phosphatase, often without symptoms, caught on surveillance labs, and diagnosis needs biopsy confirmation because that lab picture overlaps with biliary stricture, ischemia, recurrent disease, and drug toxicity, with the classic histology being the triad of portal inflammation, bile duct injury, and venous endothelial inflammation. First-line treatment is intravenous methylprednisolone, 500 to 1,000 milligrams daily for 3 days, followed by a taper and a higher calcineurin target, and most patients respond. While steroid-resistant rejection goes to T-cell depleting antibody therapy, which carries a high subsequent risk of CMV and other opportunistic infection because of the depth of immunosuppression. Antibody-mediated rejection is rarer in the liver than in other organs, because the dual blood supply and large endothelial surface blunt the effect of donor-specific antibody, and diagnosis needs both donor-specific antibody and C4d staining of the sinusoidal endothelium, treated with plasmapheresis, immunoglobulin, rituximab, and intensified maintenance. Chronic ductopenic rejection, the vanishing bile duct syndrome, shows up months to years out as cholestasis with progressive bile duct loss in over half the portal tracts, treated by intensifying immunosuppression and, when refractory, retransplant. CMV deserves its own attention as the most common opportunistic infection, with the highest risk situation being a positive donor into a negative recipient who has no pre-existing CMV immunity, and risk peaking during the most intense immunosuppression at induction and after rejection treatment. There are 2 accepted strategies: universal prophylaxis with valganciclovir 900 mg daily for 3 to 6 months in the high-risk mismatch, or preemptive weekly PCR monitoring with treatment at a viremia threshold. Disease ranges from asymptomatic viremia through a syndrome of fever, leukopenia, and thrombocytopenia to tissue-invasive disease with hepatitis, colitis, retinitis, or pneumonitis. And first-line treatment is intravenous ganciclovir 5 mg per kilogram every 12 hours, transitioning to oral valganciclovir until the virus clears, with resistance from the viral kinase mutation that normally activates ganciclovir shifting therapy to foscarnet, cidofovir, maribavir, or letermovir. The last piece is what happens to the original disease in the new graft, because the metabolic, viral, autoimmune, or biliary substrate that destroyed the first liver can reestablish itself, so surveillance continues indefinitely. Sclerosing cholangitis recurs in roughly a quarter of recipients over a decade, highest in those with active inflammatory bowel disease at transplant, recognized by intrahepatic strictures and a rising alkaline phosphatase. And the crucial part is the differential, because recurrent disease has to be separated from an anastomotic stricture treated with dilation, from ischemic cholangiopathy that may need retransplant, and from chronic rejection that needs more immunosuppression, since management diverges completely. Hepatitis C recurrence used to be the dominant late problem and essentially universal, causing much late graft loss, and direct-acting antivirals with cure rates over 95% have turned it into a manageable infection treated early once renal function is stable, with attention to the interaction between the protease inhibitors and tacrolimus. Hepatitis B recurrence is prevented by indefinite immune globulin plus a nucleotide analog, the globulin-neutralizing circulating virus, and the analog-suppressing breakthrough replication, with reduced intensity schedules now used in low-risk recipients, but the full combination kept for high-risk situations. Autoimmune hepatitis recurs in a fifth to a third of recipients and is treated like rejection with steroids and intensified baseline therapy, with a genuinely subtle histologic overlap with acute rejection that clinical context and autoantibodies help resolve. And MASH recurs commonly because the metabolic substrate persists, worsened by post-transplant weight gain and diabetes, so the new liver takes a similar insult to the old one, which is why cardiometabolic management is built into long-term care. One recognition pattern rounds this out because it shows up reliably in vignettes. Tacrolimus is metabolized by the CYP3A4 enzyme, so inhibitors raise its level and cause toxicity while inducers lower it and risk rejection. The canonical inhibitors are the azole antifungals, the macrolides erythromycin and clarithromycin, the non-dihydropyridine calcium channel blockers diltiazem and verapamil, and amiodarone. The canonical inducers are rifampin, isoniazid, phenytoin, carbamazepine, and St. John's wort. So a recipient started on fluconazole for esophageal candidiasis, who presents with new acute kidney injury, has tacrolimus toxicity from enzyme inhibition, and a recipient started on rifampin for tuberculosis, who presents with rejection, has a subtherapeutic level from enzyme induction, and recognizing the interaction in the stem is the whole test. So the longitudinal picture comes together. The score and the workup get the right patient to transplant, the exception points cover the diseases the score can't see, the donor type sets the complication profile, immunosuppression intensity organizes the early timeline of rejection and opportunistic infection with CMV, the dominant pathogen and the histologic triad, the touchstone for acute rejection, and cumulative toxicity organizes the late timeline with renal injury, de novo cancer, and metabolic syndrome. And the original disease returns in a pattern specific to its cause. Recurrent sclerosing cholangitis tracks with active bowel disease. Recurrent hepatitis B is controlled by lifelong globulin plus a nucleose TIDE. Recurrent hepatitis C is abolished by direct-acting antivirals. Recurrent autoimmune hepatitis is treated like rejection, and recurrent MASH is driven by the same metabolic substrate that destroyed the first liver. That closes the liver tumors and transplant chapter. The next chapter shifts from chronic liver disease to an acute emergency, acute pancreatitis, where the organizing question is how the diagnostic and severity criteria work, how moderate fluid resuscitation with early enteral nutrition replaced aggressive resuscitation, and how gallstone pancreatitis is managed with selective ERCP and same-admission cholecystectomy. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 4 of 4 of chapter 24, and I'll see you in the next one.